Good afternoon. With pleasure, I want to welcome you all and to the very special lecture that we have for the Henry G. Friesen International Prize in Health Research. The Friesen Prize is hosted and supported by Friends of CHR, whom we'll hear from shortly. It is truly an honor to have you all here as we celebrate a remarkable leader in health research and evidence-based medicine. Before we begin, I'll just start with the land acknowledgement. I would like to acknowledge that we are located on the territory of the Cree, Blackfoot, Métis, Stoney, Dene, Iroquois, Ojibwe, and Saulteaux lands that are now known as part of Treaties 6, 7, and 8, and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations, and we are grateful for the opportunity to learn and share knowledge on this land. With that, I'd like to welcome Dr. Tom Stelfox to bring opening remarks from the Faculty of Medicine and Dentistry at the University of Alberta.
Thank you very much, Dr. Richer. Good afternoon and welcome. My name's Tom Stelfox, and as a Deputy Dean of the Faculty of Medicine and Dentistry, it's a real pleasure to join you this afternoon for the Friesen International Prize lecture. I also want to send out a special welcome to any students in the audience. I know that unfortunately your event with Dr. Guyatt was canceled yesterday afternoon because his flight was canceled and then delayed. And so we appreciate your flexibility in attending today's event. Professional development events like what we have here today are so important for our university. We are strong supporters of these opportunities to bring together great scientists, great clinicians, and an opportunity to share, exchange, and learn from one another. Today, we have the really good fortune to host Dr. Gordon Guyatt. Dr. Guyatt has been awarded the Friesen International Prize in Health Research from our friends of the Canadian Institutes of Health Research for his global visionary work. Now, anyone who has worked as a health professional in Canada or has done clinical or health services research knows the name Dr. Guyatt. He not only coined the term evidence-based medicine 3 decades ago, but subsequently has really set the standard for what research and clinical care does when we think about evidence-based medicine. And so today, we're very fortunate to have Dr. Guyatt share with us the evolution of evidence-based medicine during a time of very rapid change in research and in healthcare delivery. And so I'd just like to finish off by saying that there really is nowhere else I'd rather be than here with you today, having a conversation about research and how we think about its implementation into clinical care. I want to thank all of you for making your way over to Corbett Hall. For most of you, this is not part of your daily routine, and for participating in today's lecture and discussion. I want to thank Dr. Guyatt for traveling all the way to Edmonton here when we're back into winter, and for sharing his time and expertise with us. I look forward to the discussion and then also to chatting with many of you afterwards at our reception. Thank you.
Thank you, Dr. Stelfox. And now to bring greetings from Friends of CHR, I'd like to introduce Dr. Peter Lewis. Dr. Lewis is the interim president of Friends of CHR. He is a professor emeritus of biochemistry at the University of Toronto, and Dr. Lewis has held many leadership roles throughout his career, including department chair. The role I currently find myself in, which he shared his condolences with me, and Associate Vice President of Research, Global Research Partnerships at the University of Toronto. He serves now as interim president and of Friends of CHR with a mission to support young scientists and enhance public engagement in health research nationally. So welcome, Dr. Lewis, and we look forward to your remarks.
So thanks, Professor Richer, much appreciated. The Friends Prize and related events today are organized, as you've heard, by the Friends of CIHR, which is a national organization focused on the support of health science in society. It is founded by Professor Emeritus Obi Angel back in the year 2000. This then is our 25th anniversary, and actually also the 25th anniversary of CIHR, and we will actually be planning an event in Ottawa this fall to celebrate that event. FCIHR advocates on behalf of young people as career scientists and encourages the funding of health research in Canada. We are supportive of the goals and ideals of CIHR and other health funding agencies, and are really eager to recruit young people to our activities across the country. As you've heard, this year we are honoring Dr. Gordon Guyatt, the 18th Henry G. Friesen Prize, International Prize winner, who was selected for his pivotal role in the development of the concept of evidence-based medicine and advancing its application to medical education, research methodology, and clinical decision-making. We started these events back in Toronto in October. In addition to the events today, Dr. Guyatt will be visiting the University of Calgary tomorrow, and then followed by McMaster in May, the University of Manitoba in June, and we're still working on the date for the UBC event, which will probably be in early July. So it's been a very busy year, but very rewarding to have these visits. So we are very pleased and grateful to Dr. Guyatt for accepting the obligations associated with the 2024 Friesen Prize, and a brief biography of Dr. Guyatt was provided in the announcement that you've seen. And I don't want to take more time away from his lecture, but I will highlight that through his long career, Dr. Guyatt has had a profound influence on the development and implementation, as you're going to hear, of the concept of evidence-based medicine. He is an aspiring and visionary scientist, clinician, and teacher and communicator. So, Gordon, we look forward to hearing your lecture.
Thanks very much. Okay, is this mic working right? Yes? Okay, fantastic. Okay, so I'm going to talk about the past, present, and future of evidence-based medicine. I'm going to start with what is evidence-based medicine. I believe it can be best characterized with three principles, and I'm going to use a historical approach. I'm going to introduce you to the folks who have made evidence-based medicine happen and have contributed to its subsequent development and where we've got to today. And I'm going to end off with EBM in the time of COVID. So this is the first paper where the term evidence-based medicine appeared in the medical literature. And just to give you an idea of how long ago that was, here's what I looked like at the time. This is my mentor, Dave Sackett. He is the mentor of a number of leaders in evidence-based medicine. He made many contributions, and one was to develop the first rather simple hierarchy of evidence. And this hierarchy for therapy looks like this. It acknowledged that clinical experience is one source of evidence, basic research, observational studies, and at the top of the hierarchy, because it is most best protects against bias, randomized trials. That hierarchy served us quite well for a period of time, a decade or more. I'm going to talk later in this presentation about the more sophisticated hierarchy that has replaced this simple one. This is Ian Chalmers. Ian Chalmers was the guy who thought of and provided the energy and vision that created the Cochrane collaboration. And the Cochrane collaboration is very important in terms of evidence-based medicine, in terms of systematic reviews. And systematic reviews, this is what we call a forest plot. Who in this audience is familiar with this sort of plot? Okay, just about everybody. And that, by the way, is a triumph of evidence-based medicine. Now, 15 years ago, when I went before clinical audiences, I had to explain this. I go in front of clinical audiences now, it comes up and everybody can understand what a forest plot is. Very gratifying. So this one is about thrombolytic therapy after myocardial infarction. And the first randomized trial of thrombolytic therapy occurred in the late 1950s, and it enrolled 23 patients, and as a result had a very wide confidence interval. The next one enrolled not 65 patients, but 42. This is a different meta-analysis than you're used to. It's cumulative. So the numbers there are the patients, all the patients enrolled in all the trials. And you can see that up until 7 trials and under 2,000 patients, the confidence interval is still crossing no effect. We don't know yet whether thrombolytic therapy is beneficial for reducing mortality. At 10 trials and over 2,500 patients, the confidence interval no longer crosses. And we could then have a discussion of when was the evidence in that thrombolytic therapy results in approximately a 25% reduction in the odds of death after myocardial infarction. Well, probably most of us would say by about 30 trials and over 6,000 patients, the confidence interval is a long way from no effect, and the p-value is getting very low. Did this stop the trialists from doing trials of thrombolytic therapy? No, it did not. And indeed, another 40,000 patients were enrolled after the answer was in, 20,000 of whom did not receive the life-prolonging benefits of thrombolytic therapy. Why did they have to go on doing trial after trial when the answer is in? The right side of this slide, I think, is really where the answer is. It looks at the recommendations made by experts while these data were accumulating, anywhere from routine, specific, calling thrombolytic therapy experimental, or not even mentioning it. 2 points about this. In the mid-1980s, you see a great deal of disagreement among the experts. Some saying, give it to everyone, some calling it only specific, some calling it experimental, and some not mentioning it. And it is a decade after the answer was in that you finally have a consensus about the experts. I've talked to the folks who are doing these trials. They said, we just got to keep doing them until these guys finally get it. Second story, prophylactic lidocaine after myocardial infarction. 45 years ago, when I was training as a medical resident in Toronto, I did a rotation through the coronary care unit, and every patient who came in the door, I started what we called a lidocaine drip, an intravenous infusion of lidocaine, because we knew that people after myocardial infarction had lethal arrhythmias, and lidocaine was a nice antiarrhythmic agent. Made perfect sense, except did the evidence ever support what I was doing? No, it did not. And you see here the randomized trials right from the beginning, in the 20 years that these data were being collected, it was always on the harm side, suggesting an increase in mortality, not a decrease with lidocaine. Mortality was never proved definitively, but any important benefit was ruled out. So when I was giving my patients lidocaine, I was subjecting them to the possible harms without any benefit. Did this stop the experts from recommending the lidocaine? No, I was giving it because through the 20 years that these data were accumulated, you see on the right side of the slide, most of the experts were recommending the use of lidocaine. And you can also see, though, once again, expert disagreement. So what do we see here among these very smart cardiologists? We see that they were a decade behind the evidence, and they were making recommendations for therapy where evidence contradicted what they were saying. Why was this happening? And what changed? Because something happened. These are old stories. They end about 1990. And something happened in 1990. Experts still disagree. They still get things wrong, but perhaps not as egregious examples as I've given here. Anybody have any idea what happened in 1990 that changed the picture so that it's much less likely you get these degree of disagreements, much less likely you have recommendations being made that do not reflect the available evidence? What happened around 1990? Any thought? No? Well, systematic reviews and meta-analysis were not around forever. Before 1990, the medical literature did not have systematic reviews and meta-analysis. They just started to appear after 1990. And I would suggest that if the experts had seen the forest plots that you have seen, they would have got the message much earlier in terms of thrombolytic therapy, and I wouldn't have been giving my patients the lidocaine that was harming them and not benefiting them. So, the third person I would like to introduce you to is Brian Haynes. Brian Haynes was chair of my current department when it was the Department of Clinical Epidemiology and Biostatistics, and he made a number of contributions which included this paper, which says evidence does not make decisions, people do. And that leads us to a somewhat ironic third principle of evidence-based medicine. Evidence never tells you what to do by itself. It's always evidence in the context of patient value differences. These two people, Hilary Llewellyn-Thomas and Annette O'Connor, were leaders in exploring patient values and preferences. And to illustrate this principle, I'm going to introduce you to P.J. Devereux, who is currently leading the world in perioperative preventing cardiovascular events in people undergoing non-cardiac surgery. But before he did that, he conducted the following study. And in a little while, I'm going to ask you, I'm going to repeat the study and ask to be the participants. So listen carefully. So the situation is people with atrial fibrillation without treatment, 100 patients will suffer 12 strokes, 6 major and 6 minor, and 3 serious bleeds. Anticoagulation would decrease strokes in 100 patients to 4, 8 fewer strokes, 4 major and 4 minor prevented. And the question that Dr. Devereux asked his study participants, and I'm going to ask you shortly, is how many serious gastrointestinal bleeds would you tolerate either as a patient or in terms of recommending for patients if you were the caregiver and still be ready to administer anticoagulants? Well, Dr. Devereux asked this question of patients and clinicians. He had to make sure that the patients understood what it was like to have a stroke and a bleed. So here's what he told people about a minor stroke. You suddenly can't move or feel one arm and leg, difficulty expressing yourself, no pain, you're admitted to hospital, things improve, you still have a minor disability at the end of that, and you go home and more or less resume your active life. Major stroke, much worse. Unable to move an arm and a leg, can't swallow or control your bladder and bowel, unable to understand or talk, admitted to hospital, can't dress, walk, the nurse has to feed you, you improve to some extent, but you're left with major disability and not able to conduct a productive life after that. So that's a minor stroke and a major stroke. And Dr. Devereux also told his patients what it's like to have a major gastrointestinal bleed. Feel unwell, you vomit blood, pretty frightening, admitted to the hospital, you have an endoscopy, receive sedation, don't need an operation, receive a blood transfusion, stay in hospital for a week. By the time you leave, you're feeling considerably better. And so let's go, now that we've established what it is to have a major and minor stroke, we've established what it is to have a serious gastrointestinal bleed, let's ask our key question. So again, without treatment, 100 patients with atrial fibrillation will suffer 12 strokes, 6 major and 6 minor. Anticoagulation would decrease those strokes from 12 to 4. 8 strokes prevented. 4 of the strokes prevented are major and 4 are minor. How many serious gastrointestinal bleeds would you accept in 100 patients and still be ready to give the anticoagulants given the stroke prevention? So who would be willing to give 5 or fewer, to tolerate 5 or fewer bleeds? More than 5 bleeds, no anticoagulation. Anybody 5 or fewer? Nobody in this audience 5 or fewer. How about 10? Tolerate up to 10 bleeds, but no more than 10. Okay, we have, I don't know, 25% of the audience, 25. Who would tolerate 15? Stop. Once you put up your hand, don't do it again. Who would tolerate up to 15? No more than 15. Okay, another, quite a few people. Who would tolerate up to 20? Up to 20 bleeds, okay? A few people. Anybody would tolerate more than 20 bleeds? A couple of people would tolerate more than 20 bleeds. Okay, here is what happened when Dr. Devereux asked his patients and his physicians. Let's look first at the physicians, which is the blue-green, a very flat distribution. So this audience was a little bit different to here. Nobody was less than 5. But after that, it was more or less the same, the similar flat distribution, with some being 5 to 10 and some going up to over 20 bleeds. So very different answers, which means, using the EBM language, very different values and preferences among the physicians. What about the patients? 2/3 of the patients were ready to tolerate 22 bleeds. Why 22? Seems like a bit of an odd number. Well, when Dr. Devereux constructed his study, he was thinking like a physician. He thought nobody would go above 22. If you had given them the chance, they would have. But there's another thing here. Although the patients are much more stroke averse and much less bleeding averse than are the physicians, who are much more bleeding averse and less stroke averse, that isn't all the patients. Look, there are some patients over at the other end with values and preferences that are more like the physicians, more bleeding averse and less stroke averse. So what are the messages here? First of all, if you go with the physician's values and preferences, that's a big problem. We should be going with the patient's values and preferences. But there's a second message. If we want to get it right for the individual patient, because individual patient values and preferences differ, we have to engage the individual patient with the decision-making in a process we call shared decision-making. So, 3 principles of evidence-based medicine. Some evidence is more trustworthy than others, and evidence-based medicine provides a guide of saying what is more and less trustworthy. Simple guide that you've seen earlier, and more sophisticated guide that I'm going to tell you about shortly. Second, the best clinical care demands systematic reviews of the best evidence. You've seen what the cardiologists, these smart cardiologists, how far behind the evidence they were, how they were making recommendations contradicting the evidence. Things would not have been nearly so bad had they had systematic reviews available to them, but that's only, in the big scale of things, a relatively recent phenomenon. And finally, the third, somewhat ironic principle of evidence-based medicine: evidence by itself never tells you what to do. It's always evidence in the context of patient values and preferences. So, having established those 3 principles, I'm going to introduce you to Andy Oxman, who worked with us at McMaster for a decade before he then went to Norway. And his idea was something that we've called GRADE. GRADE is a system to judge the confidence or certainty in the evidence from systematic reviews, and also how to move from evidence to recommendations. And this was an attempt to solve a problem of when guidelines were if you go to around 2000, when guidelines were being developed, everybody had a different idea about how to decide about the quality or certainty of the evidence and how to get from evidence to recommendations. And this was an attempt to standardize that process and come up, a group of guideline developers and methodologists got together, came up with a suggestion that we called this grade process, and it has been pretty successful. Over 120 organizations worldwide have adopted grade. They include very prominent ones like the World Health Organization, the Cochrane Collaboration, leading American groups like the American Thoracic Society and the American College of Physicians, and perhaps, maybe the most important, the leading electronic textbook worldwide that clinicians use to guide their care, up to date, has over 10,000 graded recommendations. So one reason to pay attention to this next bit is you will see a lot of grade. So this is the more sophisticated hierarchy. You remember Dr. Sackett's relatively simple hierarchy. This is one. On the right side of this slide, you see the 4 categories of evidence: high, moderate, low, and very low. Randomized trials start in this hierarchy as high certainty evidence, but they may not stay as high certainty evidence. The randomized trials may be unblinded, unconcealed, and lose lots of patients to follow up, problems with bias. They may be relatively few patients, few trials with few patients, wide confidence intervals, imprecision. There may be indirectness. I work as a hospital-based general internist, and I try to treat my patients on the basis of randomized trials. But I now have lots and lots of patients over 80, and I have quite a few patients over 90. Not many such individuals participated in those randomized trials. So I am not quite so sure about applying those results to my patients over 80 or over 90. The randomized trials in the younger patients provide indirect evidence for my older patients. Results, we also lose certainty if the results are inconsistent. Some trials suggest benefit, some do not. And we also worry about publication bias. So randomized trials start as high quality or certainty of evidence, but these 5 categories of problems can lower the evidence. Observational studies start as low certainty evidence, but sometimes observational studies can tell us that treatment, can give us convincing evidence that treatment works. Who manages patients that can tell me something that you do that hasn't been tested in randomized trials, but that you are sure benefits your patient? Anybody have any suggestions? Yes. I want one thing you do that you are sure benefits people. Benefits that you are sure benefits people. Something you do, no randomized trials, but you're sure it benefits people. Good epinephrine and anaphylactic shock. We know it benefits, even though no randomized trials. What else? Sorry? I wouldn't agree with that. I would think that we would need trials to be sure that that helped. Yes? Parachutes, okay, good. Come on, that's not a medical, no, come on, medical interventions. Okay. How about resuscitation after cardiac arrest? Okay. How about dialysis in people with terminal renal failure? How about putting in a tube and intubating somebody whose PCO2 is 100 and rising? Okay. We do have a number of things. How about hip replacement in severe osteoarthritis? I can tell you, I've had 2 of them. So there are these things. None of those have been tested in randomized trials. What do they all have in common? What do they all have in common? What they all have in common is very large effects. Everybody or almost everybody used to do badly with a typically downhill course, and now the trajectory has changed in a substantial amount of people very quickly. So bottom line is, in this more sophisticated hierarchy, randomized trials start at the top, but lots of reasons they may not stay at the top. They may go to moderate, low, or even very low certainty evidence. Observational studies start low and can go very low, but in certain instances, they can go to the top as well. Much more sophisticated hierarchy. All right, and then we end up with grade suggestion of how you present the evidence. This evidence is for baricitinib in patients with severe or critical COVID. The first column on the left tells you what the outcomes are, like mortality, mechanical ventilation, hospital length of stay. The next gives the relative effect. The next two columns, what patients are really interested in, which is not relative but absolute effect. In this case, applying the relative effect to the baseline risk of a 13% mortality. If that odds ratio of 0.62 is right, then there would be 85 instead of 130 deaths. Confidence interval below captures that. Next column is the certainty of evidence, and then the final, a plain language summary, telling you in this case, baricitinib probably reduces mortality. So that is the grade summary of findings table, which many of us find very useful in summarizing the evidence for us. So we've talked about how grade deals with evidence. We're now going to talk about moving from evidence to recommendations. Grade has a very simple two-category rating of evidence, of recommendations. A strong recommendation when benefits clearly outweigh the downsides, or vice versa. What can move us from a strong recommendation to a weak or synonym conditional recommendation? Low confidence or certainty in the evidence. If we only have, we only were going to make a strong recommendation if the benefits clearly outweigh the downsides, or vice versa. If you're not sure of the benefits and or you're not sure of the downsides, pretty difficult to be sure that one outweighs the other. So low certainty or confidence in the evidence will move you from a strong to a weak recommendation. And the other one is, we may have high certainty evidence, but the benefits and the downsides may be closely balanced. And we've seen that patient values and preferences differ widely. And when the benefits and the downsides are closely balanced, because of different patient values and preferences, you're going to have patients making different choices, and that's what a conditional or weak recommendation means. It has to do with variability in patient values and preferences. If all or almost all fully informed patients would make the same choice, you're going to give a strong recommendation. If fully informed patients, because of different values and preferences and a close balance or low certainty evidence, a close balance between benefits and downsides, they make different choices, a panel gives a weak or conditional recommendation. And this turns out to be very useful. When I go around the world lecturing to medical audiences, there's one question I ask where I always get the same answer wherever I am in the world, and it's 100% or almost 100%, and every audience gives the same answer. And that question is, do you have enough time to spend with your patients? And everybody says, no, I don't have enough time, which means that we have to ration our time with our patients. We don't have as much time as we would like, and we have to use that time wisely. And grade can help us with that. If a guideline panel has got it right and makes a strong recommendation, it means if we went through a full shared decision-making exercise, all or almost all people would make the same choice. That's not a great way to use our constrained time. On the other hand, if a panel has got it right in a weak and conditional recommendation, it means that if you did go through the shared decision-making, some would say yes and some would say no. And then if you want to get it right for the patient, you need to do that. So grade can help us with this interaction with the patient by if we understand what a strong recommendation conveys and what a weak or conditional recommendation may. Shared decision-making is challenging. EBM offers decision aids. It's something that we still need to do better and more of. but a decision aid might be a waste of time with a strong recommendation. You know, everybody or almost everybody is going to make the same choice at the end, but in a weak or conditional recommendation, it can be very useful. So guidelines can only use average values and preferences, right? They're making a recommendation for a whole group of people. You can only think of average. But at the point of care, we know, as we just talked about in the conditional recommendation system, people are going to make different choices. And if we're going to get it right for the patient, we have to communicate the evidence and help them to come to their choice. And decision aids can help. This is Victor Montori. He's a professor of medicine at Mayo Clinic. He's an endocrinologist, and he deals with a lot of patients with diabetes. And he has come up with this decision aid for patients with diabetes. He asked them, what aspect of your next diabetes medicine would you like to discuss first? And there's lots of alternatives nowadays, and he has cards. And these cards have weight change, low blood sugar, hypoglycemia, how much it lowers your blood sugar, daily routine, sugar testing cost. And he asked patients, which would you like to know about first? What do you think the most popular first choice is? No guesses? Weight change is right. Victor tells me 40% of the patients or more choose weight change as their first. And then they may choose daily routine, they may choose cost, and they may want to look at all 6 cards, except they never do. They are certainly able to make their choice after 4, many after 3, and some after 2. This is efficient shared decision-making, tailoring the information to what the individual patient would like to see. And I think it will work. It was earlier. I will show you a video clip of Victor using the cards.
So yes, I agree. We need to make sure your sugars are better controlled. So that means we need a new medication. So which aspect of your next diabetes medication do you want to discuss first?
Weight change.
Weight change? I'll let you review that.
Okay. So this is the one that I'm on.
Yeah, you're already on metformin.
Well, this one looks good to me.
Yeah, that one is going to help you lose some weight.
Yeah.
What aspect of that medication would you like to learn about next?
I'd say the daily routine.
Sure.
Okay, so.
Yeah.
Oh, so this is an injectable.
Yeah, it's actually very easy. There are a couple of pens that have needles, and you inject the needle into your belly and do that twice a day before your meals.
Yeah, I don't think I really want.
You don't want to go needles?
No,
Okay.
no. I'd much rather just pills. So this is okay. Well then, so the sulfonylureas.
That's the next
So
best
this
one
one-
for you in terms of the weight, huh?
Yeah, yeah.
Well, that's a daily pill, so that you can start with just 1 pill a day.
Yep, and just 30 minutes beforehand.
Yeah, usually 30 minutes before breakfast. Would that be okay?
Yeah, yeah.
Okay, well, the other thing to consider is that sometimes they can give you low blood sugar, so we're going to ask you to monitor a little more often than you're doing right now, but otherwise that will be okay. If you were to change your mind after you go home, I'll give you this pamphlet. It has the same thing as the cards, so as you're using the tablet, if you find that it's not what you were expecting, review this again and give me a call and we can discuss it again.
Okay.
All right, thank you.
So, evidence-based shared decision-making in a minute and a half. It doesn't always go that smoothly. However, it shows you how these cards are a wonderful innovation in terms of you don't have to tell the patients everything, you tell them what they are interested in and want to know. Deborah Cook and Maureen Mead are intensive care physicians, and I'm going to tell you something. They have contributed to EBM in the intensive care world, and I'm going to tell you what I think is a very impressive innovation that Deborah Cook led. She calls it the 3 Wishes Project, and what she does is to ask patients and families what are there in patients who it's clear that they are terminal, what is their last 3 wishes. So for patients Her goal is to honor their inherent dignity, for families to humanize the dying process and support them in their grief, and for clinicians to inspire a deeper sense of vocation. Wishes may be those of patients, family, friends, or clinicians. What matters most at the end of life is usually simple. For some people, it can be flowers at the bedside. It can be a visit from someone they had not seen from a long time, although sometimes it's more dramatic with, for instance, a marriage ceremony made at the bedside of the dying patient. It gives voice to the patient, voice to the family, and it has been very popular worldwide. There's now a worldwide program of the 3 wishes to humanize the dying process. And finally, of the major characters, Per van Vijk. Per van Vijk is Norwegian, was with us for a year, learning how we could make trustworthy guidelines. And so his trustworthy guidelines that Per worked with, ones that we developed for the American College of Chest Physicians, we of course used GRADE. And he said, we thought these were great guidelines. Per was not so sure. He said, are they available and useful and understandable? Maybe. Are they suitable for integration into electronic medical records? No, I don't think so. Are they sufficiently up to date? No. Major organizations are still doing this. They get together, they get a panel, they do a lot of work, they summarize the evidence, they make their recommendations, and then they're all so tired they go away and they don't do it for 3 years again. Guess what happens during those 3 years? New evidence accumulates and the old recommendations became outmoded and as a result, misguided. So that is a problem. Do they facilitate shared decision-making? No, they're not made to facilitate shared decision-making. So he asked the question, how can we make GRADE irresistible for clinicians, patients, and guideline developers? And he decided that what we need to do that is MAGIC, which stands for making GRADE the irresistible choice. And we decided, so we need living guidelines. You can't wait 3 years. You can't make your recommendations and wait 3 years. We know we need living guidelines, but nobody was doing it. So Per made a deal with the British Medical Journal, and said, let's produce BMJ rapid recommendations, where what the group does is they scan the literature when there's new practice changing evidence that's emerged, quickly do the systematic review. We know how to do them quickly now. Quickly get a panel together. We know how to do that to produce trustworthy guidelines. Started in 2016, and they produced lots of BMJ rapid recommendations. And what particularly aids in this process is an electronic platform for producing the guidelines and then disseminating them. And it's analogous to Lego blocks, where you have the PICO, the question, you have the summaries of the evidence, like the evidence profile I've shown you. You can even go back to the individual studies. And through this database, you can end up putting the recommendations on smartphones. You can integrate them into the electronic medical record. It helps you with adaptation of the recommendations, and it allows the production and dissemination of decision aids. Show you a little bit more about that in a minute. Next guy is Thomas Agaritsis. Thomas did a PhD with us at McMaster. He now works in Geneva, and he is a key player in the MAGIC team. And one of his contributions was the semi-automatic production of these decision aids. What allows that? Systematic reviews built on GRADE principles, in those summary of findings table that I told you about. The evolution of decision aids, Victor Montori's approach that allows efficiency by focusing in on what, you don't have to tell people everything, focusing in on what people need to know, and the MAGIC app. And so what that has allowed us to do within the context of COVID, these two people, Reid Semenchuk and Romina Brignardello, put together what we needed doing during COVID, which is network meta-analysis and innovation in EBM. It used to be just one treatment, one control. Now we have statistical approaches to look at simultaneously at multiple possible interventions. And they organized a living systematic review and meta-analysis. At the peak, they were processing 20 randomized trials a week. Okay, they did that with a team of 60 methodologists. McMaster was one of the few places in the world that could do that because of all the people who were training all the time. What they produced informed the World Health Organization. And then Pear and his magic colleagues made a deal with the World Health Organization, bringing them together with BMJ, so that when the day that the World Health Organization publishes their recommendations for their particular audience, it appears on the same day in the BMJ with WHO rapid recommendations. So this is the living WHO guideline, and I need some help here. I am now going to show you with the magic app if all goes well. We need to put it over on this side apparently to have what should be happening. And I knew that I would not be the right person to be doing this. So I insisted that we have someone at the ready, and except it didn't go to where I want to go. Unfortunately, let's see what happens here. This is the last slide. This is the last picture I want to show. It should have gone to, when I do it, I just click on that at the bottom and it takes me to the right place, that link. No? If you hit that link, that's what when I am able to do this myself, I just take yes, I think it's going to, yes, thank you, you've done it. Hey, thank you very much. Okay, very good. All right, so here you go to the recommendations. Nirmatrelvir, ritonavir, otherwise known as Paxlovid, is the best treatment for non-severe COVID. And when you then go, you will find out that the recommendations that the WHO and then appear in the BMJ made a strong recommendation for patients at high risk of hospitalization. But they only made a conditional recommendation for patients at moderate risk of hospitalization. And it's that we're going to do. And if you're that sort of clinician, they've told you, okay, conditional recommendation in favor, perhaps that's all you want to know. But you may want to be the type of physician who would like to know about the research evidence. And if you want the research evidence, you can go to one of these summary of findings tables. There we are. Whoops. Whoa, what's going on here? Okay, I think I've saved myself. Thanks very much. Okay, so here's the summary. Remember these summary of findings tables. You have mortality and admission to hospital. You have another mortality and admission to hospital. What's that about? Well, the first one is for the high risk people. The second one, the moderate risk people that we're going to be interested in. Okay, and then the grade has this evidence to decision framework. And you can say, applying this, what are the benefits and harms? What's the certainty of the evidence? What do they think of patient values and preferences, resources, and other considerations? You want to know how they justified their recommendation, you can go there. And if you're this sort of physician, you just look at their recommendations, and then you go to practical information with route, dosage, and duration, and also a key thing with nirmatrelvir, ritonavir, it interacts with a lot of other drugs. Or you can go, if you want to involve your patient in shared decision-making, you can go to a decision aid. And so in the shared decision-making, you can direct your patient and you can say, the real action here is for admission to hospital. This one will take us to the high risk. This one too will take it to the low risk. And this one takes us to the one we want, the intermediate risk. and we find out that there is a 2.5% reduction in the admission to hospital in those who receive Paxlovid and those who don't. But the patients may want a little help with these numbers, and so you can show them this, which is 1,000 representations of people. You can see that if you look at the black and the orange, that is the total 30 out of 1,000 who will have the experience of being hospitalized. If they don't use nirmatrelvir, but ritonavir, the black are the 5 who will still get hospitalized, and the orange, the 25 who in 1,000 who would have been hospitalized, but would not if they take the treatment. So now I want to go back to, let's see, will this do it? This will do it. I got it. Thank you. All right. Okay. So that's how the Magic app, it's a platform. It's a platform for creating the guideline in the first place. And then you can see it's a platform for a layered approach to information so that it is right for the physician who just wants to be told what to do, and it is right for the physician who wants to look at the evidence, and it is right for the physician who wants to do shared decision making and would like to use a decision aid. So EBM in the time of COVID with respect to medication, with respect to drugs, to me, a triumph of EBM and what it can do. Unprecedented rapid production of the evidence, the use of innovation in trial methodology, platform trials where you set up your structure for doing the trial, you test one treatment, you finish with that, you still have the structure, you move to the next treatment. You finish that, you move to the next treatment. And in 2 years, we had 3 medications that reduce mortality in severe, in non-severe, and 3 classes of medication that we know reduce mortality in severe. Produced all that from randomized trials in a 2-year period. And then we have more collaboration from the trialists in sharing information. We were able to do these rapid guidelines with the World Health Organization, create the network meta-analysis that got the information, and then with the World Health Organization, and other folks were doing it too, rapidly producing recommendations, which, as I've told you, was in these 2 formats, one for the WHO audience and one with the BMJ. So, in conclusion, the 3 principles of evidence-based medicine are widely acknowledged. Some evidence is more trustworthy than others, and EBM now has this sophisticated hierarchy of evidence to tell you what evidence is more trustworthy than others. We need systematic reviews and guidelines. You saw how badly these smart cardiologists went wrong before they had systematic reviews to summarize the evidence for them. And the third ironic principle of evidence-based medicine, evidence never tells you what to do by itself. It's always evidence in the context of patient values and preferences. And I would say the COVID epidemic showed us to a considerable extent the full potential of EBM, the rapid accumulation of trustworthy evidence, the rapid incorporation into state-of-the-art evidence summaries, these living network meta-analyses, and then into living guidelines. So that is my summary of evidence-based medicine. I think we can turn this off. And now, thank you. Thank you very much.